Welcome. We're going to get started today. My name is Peggy Hoosier. I am the COO of Advanced Health Education Center, and my job responsibilities here vary. I run the operation of the center here in Houston, but I also participate in the mammography program. The majority of my experience in the last 20 years in the area of imaging has been in mammography. So I'm going to be the presenter for the first part of the program. Then we'll be introducing Deborah Thames. Deborah Thames is a registered technologist, also credentialed in mammography and QM. She is a faculty member here at Advanced Health, teaches in our initial training program in mammography. But Deborah is also a full-time employee with MD Anderson Hospital. She's a mammography specialist there and works on their mobile unit. So when we get to the part about the image quality and the quality parameters that we're going to be reviewing, Deborah will be providing that part of the program. So let's talk first about our training objective. We're going to be reviewing the components of mammography accreditation as it relates to image quality. We're going to review the ACR clinical image parameters, and we're going to provide the interpreting physicians with some of the technical knowledge that they'll need to communicate so that they can communicate the quality expectations to their mammography technologists. Hopefully we'll be able to provide the interpreting physicians with some of the technical jargon that will help them be able to communicate effectively with their imaging, their mammography technologists. And so the topics for today are going to be MQSA review. Then we'll be looking at the 8 ACR clinical image review parameters and examining each one of those. Those will be accompanied by mammographic images. Deborah will be demonstrating positioning, good positioning, bad positioning, positioning deficiencies. She'll demonstrate adequate and inadequate compression, as well as over and under exposures, talk about sharpness, contrast, noise, artifacts, required information on exam identification, labeling. Also spend a little bit of time talking about radiation safety as it relates to mammography, and then the new EQUIP initiatives that are going into place in 2017. But I'm going to start by talking about MQSA, the Mammogram Quality Standards Act. Mammogram Quality Standards Act is intended to improve the quality of mammography. It's the bottom line. The intent of the program from the get-go was to be able to educate and improve. And I would certainly say, based on my experience with the program and mammography over the last 20, 25 years, is the intent of the program has been met. We certainly have improved the quality of the mammogram, the procedure that we're providing the patient, and the interpretation that the physician is providing. All of those things have come together, and what we see today is certainly improved over what we saw many years back. And even when you look at films done today and compare them to mammograms that were done last year or the year before, we can see that the quality of the image has improved. And so we know that the things that are in place for mammography and the standards that have been set have improved the quality of the procedure and ultimately improved the quality of the interpretation, which translates to an improved quality of care for our patients. Now, having said that, it hasn't always been an easy process, and having been involved from the beginning of mammography. I trained in mammography and did mammography as a mammography technologist before there was dedicated equipment. Certainly before that we use compression consistently. And I know that the quality of procedure that I provided then compared to what we give our patients now is light years better than what it was. But it has been a bumpy road. It has been difficult. It's been expensive. We've been under the scrutiny not only of the federal law that regulates the performance of this procedure, but also the public. And so we're going to talk a little bit about that before we get into the technical parameters. So mammography has been an umbrella, and as I said, it's been a rocky road. It's been hard because it's been expensive. It's required changes in equipment and in technology and in clinical practice. So we've had to meet standards in a multitude of different areas. The ACR, the FDA, the states, MQSA. It's an umbrella now where there's a multitude of regulations that have to be met to be able to continue to perform mammography. So I always like to say that caution, this is high information area because what we're providing is information about the overall program and some of the fundamental parts of it. And then I think you'll be able to draw the parallels between the beginning program and some of the things we're looking at in mammography accreditation and compliance in 2017. So we're going to look at the state of mammography, the driving forces in healthcare overall. Mammography is a healthcare procedure. It is in the realm of imaging, but in the overall healthcare scenario, what we know and what we all know is that we're being controlled by cost and money. The second factor that is very apparent in the healthcare industry now overall is not only money and cost control, but increased efficiency, the whole do more with less. And then the third parameter, or the third component that they talk about is improved quality of care. Well, having been around in the healthcare community for many years, I know that a lot of times controlling the cost and increasing efficiency did not always relate or equal improved quality of care. And in fact, in many cases over the last 20 to 25 years, those cost controls and increased efficiency have resulted in a decrease in the quality of care. And certainly in today's overall healthcare scenario, where it's one of the most important areas in our whole public arena, is that everybody is focused on quality of care and the cost and, of course, efficiency. We all want to be efficient, but it hasn't always been easy. So in mammography, the whole cost control issue meant that we had the same number of mammograms during reduced hours, maybe less staff to perform those. And so we've tried to be able to continue to meet the quality standards and to improve the quality of care. But in many cases, that had to happen with less staff to perform the mammograms, fewer physicians to interpret them, meaning that the fewer physicians that were interpreting larger numbers of mammograms. So the whole cost control issue had an impact on the quality of mammography. And another overriding issue is the increase in efficiency, workloads, perform exams more efficiently. What about quality? As I said, some of the things that we've done to control costs and increase efficiency haven't always led to the quality of care for the patient or the quality of the procedure or the quality of the interpretation. So we've had a lot of roadblocks that have been difficult to overcome. Not making excuses or just talking about the overall state of where we are in healthcare in mammography. And because we have a high compliance area in mammography, more so than in any other imaging modality, and a low reimbursement. So those two things together make it even more difficult in today's healthcare climate to make this all come together. So we talk about the shoot 'em and scoot 'em environment where we're trying to get more patients in and more patients out because we need the revenue and the throughput. So we focused on increasing efficiency, and now we're looking at the quality. And certainly there's nobody that gets up on any given day and says, I think I'll do some bad procedures today. I think I'll interpret them incorrectly. We're all trying to march to the same beat of the same drummer, but we're setting a stage where it's difficult. And so we're going to look at how we can overcome some of those difficulties and truly focus on the overall quality of the procedure. So, improve quality of care of patients. We're all healthcare consumers, whether we may work in a healthcare industry, but we all consume healthcare for us, for our families. And we all want the same thing. We all want, to be treated appropriately and the best quality of care because obviously we're paying top dollar. There are a lot of public expectations too because of the advent of all of the advertising that's done. When I started in healthcare many years ago, you didn't see advertisements for hospitals or facilities or for, come to our facility. We offer, valet parking and a cappuccino machine in the waiting area. But in today's healthcare market, those are actually some of the things that we're seeing. So we have a lot of public expectations of what our quality of care is. Very public in the area of mammography. There's probably more public information out there regarding mammography than any other quality or any other imaging procedure. Patients see it on the television. There's exposés. There's, you just about can't pick up anything that doesn't have something in it about mammography. So the public is well informed, and sometimes I like to say well informed, but maybe not so well informed about what the procedure of mammography is, what it can do, what is the efficacy of the procedure. So there's a lot of public information, and it's not all correct about mammography. So we have the patient's expectations also. When they come to us for the procedure of mammography, they may ask questions like, is this an ACR accredited facility? Are your technologists licensed to perform mammography? Is your physician qualified to interpret it? Well, I assure you, if they show up for their diagnostic imaging procedure and for a chest x-ray, they're probably not going to ask the same kind of questions. So the scrutiny in mammography is much greater than in other areas because it has become a public procedure. And then they have their quality expectations and then their own personal expectations. Possibly they've had a bad experience. And I know from a technical perspective as a mammographer, I even imaged a patient before in mammography that tell me how wonderful the procedure was and what a great job I had done. And in the very same breath, she tells me what a poor experience she had had in a previous procedure at our facility. Well, unfortunately, when I went back to look at the records, I provided that previous procedure. So what happened between that procedure a year ago and this one that all of a sudden I had done such a good job compared to what I had done last year? So people have their own personal expectations when they come for the procedure. So I call mammography a very public procedure, and they know a lot about the procedure. Some of that is not all good information. And so when you're facing this and you're dealing with a patient, whether it's a technologist doing the procedure or a physician explaining the interpretation, we have to be aware that the patient's expectations in the area of mammography are not the same as they are in other areas. I just want to share this because I always talk about being a very public procedure and about advertising for our facilities. And this is actually something I got in the mail many years back, but was get a mammogram at Macy's, and I think this has gone away, or I know it has. But there was a point in time where you could go to Macy's at the gallery in Houston, and they had a remote location, and you could put your name in for a $500 wardrobe drawing, and you could get your mammogram. Well, that's advertising at its greatest. So it's not only a public procedure, it is a procedure that is in the media also. So when you begin to look at mammo services, it's difficult because, as I said, they don't take into account all of the physical resources, the human resources, and the compliance costs that go into performing, reading, and providing the interpretation and the communication of the results. They don't take into account all of the costs that are associated with providing good mammography services. So it doesn't start with the procedure or end with the physician. There are a multitude of other things that have to be provided to be able to provide good mammography, starting with your physical resources and your equipment, and then your human resources from the time somebody walks in or they schedule their procedure, to after the procedure, after it's been done by the technologist and interpreted by the physician, the communication of the results, the medical audit, the things that have to be done. So we're talking about significant physical, human, and compliance costs when you're providing mammography services. And again, I said, we have high compliance and low reimbursements. Makes it even more difficult to make sure that you're dotting all your I's and crossing all your T's in your mammography program. So we're going to talk a little bit now about the accreditation program and not go into a lot of depth, but I do think there are some things that we'll look at and we'll see that help explain kind of where we are and where we're going with the accreditation process. ACR accreditation program prior to MQSA. So mammography accreditation is not new. And in fact, it was developed in 1987 by an ACR task force on breast cancer. At the time, the ACR recognized the need to address an improvement in quality in mammography. And so they voluntarily developed this program. Within the ACR, the program was directed and implemented by radiologists and medical physicists who were part of a committee within the ACR. And they saw what I think is one of the greatest advantages of this program. This was to be a program, yes, to address all of the quality parameters, but also a peer review program. And in their wisdom in the beginning, because it was a peer review program, all the reports, the documentation, the correspondence between the ACR and those facilities that chose to participate was privileged and confidential. And here's one of the components that is in MQSA, but sometimes I don't think that we always refer back to it as we should. The whole intent is to improve the quality of the procedure. It shouldn't be focused on anything that's punitive. it is about education. It is about peer review. It's about inviting people into your program, into your facility, to be able to say, hey, you do this really well. This needs to be improved. This needs to be done. So sometimes I think we get so focused on the accreditation issues and the I's, dotting the I's and crossing the T's, that we have to back up and remember what the overall intent of the program is. This initial ACR accreditation MAP program provided facilities with peer review and constructive feedback when it came to staff qualifications, quality control, quality assurance, and ultimately on image quality. And so you'll see those that it's interesting because when the FDA began to talk about implementing mammography quality standards, they went and modeled after the ACR program. So in 1992, when the federal legislation was being drafted, it was after the ACR's accreditation program, and they knew that it had been successful in improving the overall quality of the mammographic procedure and, of course, the mammographic image. So in 1994, when MQSA was passed, it was very similar in scope to what we saw with the voluntary program that ACR had. The initial qualifications, or the initial federal law, became effective on October 1st of 1994, where all facilities that were performing mammography in the United States, accepting any care, Medicare, or Medicaid reimbursements, had to be accredited by a recognized entity. Well, obviously, because the ACR had been involved, they became one of the accrediting bodies, and in the beginning were the only accrediting body. So the FDA is oversees MQSA. It is a federal law. Mammography is the only radiographic procedure regulated by a federal law. And as such, noncompliance can result in fines or sanctions. And so MQSA requires all mammography facilities to be accredited by an approved body, then certified by the Department of Health and Human Services, and inspected by the HHS, or a state agency acting on their behalf. So all of these things have to occur for a facility to be able to be accredited. Now, there are some states that have been recognized as accrediting body. Texas is one of those. Iowa is another one. Arkansas, and I hope I'm not forgetting one, but I know for sure those three. I think Iowa is also in that mix. So if you're in the state of Texas, you have the ability to choose whether you're going to go with ACR accreditation or the Texas Mammography Accreditation Program. If you're in a state that doesn't have a state that is a recognized accreditation body, then your only choice would be through the ACR, the American College of Radiology. And so once the accrediting body has approved a facility and they have met all of the criteria, the components as outlined in the federal law, then they notify the Department of Health and Human Services that then certifies the facility. The inspections occur annually, and they may be an MQSA inspector, but more often than not, they're a state agency inspector that is acting on behalf of the FDA. Now, the qualifications or the components of the program that you have to meet are the same. Some states, and Texas is one of those, have accreditation criteria that in some places is more stringent than MQSA. So you have to meet the minimum standards as outlined by the federal law in MQSA, but as a state's accrediting body, you could potentially have criteria that are above and beyond what is required by MQSA. So that's just a little bit of an overview of how it all works. One of the things that we see that was present in the ACR voluntary program prior to MQSA is personnel requirements, where there are minimum standards, whether you're the physician, you're the radiologic technologist, or you're the medical physicist. And each one of those personnel requirements have initial training requirements, those requirements that have to be met before you can actually perform the procedure or interpret the procedure. Then you have clinical experience requirements that have to be met for you to be able to continue to do those. And then each one of the categories also has a continuing education component where they actually tell you what the number of procedures or the number of CEs that you're going to need to do and specify some of the topic areas that need to be included. So we've seen that personnel requirement also in other accreditation programs because many of the accreditation programs that you see in an imaging department these days all fell back to some of the same components as mammography accreditation. So if you're in a facility that has MRI and CT and ultrasound, you probably may be dealing with accreditation programs in those specialty areas. And so most of the components of the program are the same. Obviously, they're specific to the resulting or to the modality, but the overall components of the accreditation program all have some of the same things. And one of those, of course, is personnel requirements with an initial, a clinical experience factor, and a continuing education. Now, we're not going to get into a lot of detail about what, because that's not the overall objective of the training course, but physicians have their initial qualifications that they have to meet. There's alternatives if they're not board certified in radiology, and you'll see that in all components where if you're not certified in board certified in radiology, then there's an alternative path to being able to become qualified initially. Then you'll see that it has continuing experience and continuing education. And the experience for the physician is based on numbers of mammographic exams over a period of 24 months with a number of 960. And so in each of these categories for the different participating personnel in a mammography program, you're going to see the continuing experience with a number and the continuing education also with a number. Physicians, the continuing education, 15 category 1 CME units in mammography in a 36-month period. I might mention that this will be 3 hours of category 1 CME specific to mammography for completion of this activity. And then for the technologists, the same thing. Like I said, we're not getting into all the rules and regulations, but it does give you some appreciation for the people that actually are credentialing everybody and making sure that all of their paperwork is in order. Trying to document initial training, the experience, and the CE are all things that have to be documented and available for your MQSA on-site inspections. Gotten many calls over the years for somebody that didn't have their initial training certificate in mammography or their CE where, they had lost it in the flood, and we were trying to recreate certificates for them to be able to document that they indeed did have the information that they needed. At least 8 hours of training in each mammography modality be used by the technologist in performing exams. That wasn't in the original law, but of course they had to come back. And when they finalized the rules for MQSA, in 1999, they had to come back and address some of the new imaging modalities. One of those, of course, was in digital. So the other components of Mammography Quality Standards Act that you're going to see, regardless of the kind of program, whether it's mammo or CT or MR, they're going to have quality control. They have minimum frequency for testing established, both for the medical physicists and the technologists in the mammography programs have required testing in addition to the annual physicist survey. Equipment requirements, and then quality assurance, and that's painted with a broad brush, but it's actually where we are in some of the things that we're going to be talking about, especially when we talk about the new EQUIP initiatives, where they have had things in quality assurance outlined under MQSA that were recommended, and in some cases strongly recommended. Well, we have seen that language used over the years where something that was recommended eventually made its way into the final rules as a requirement. But I think we're seeing the progression of the quality assurance area where they suggested that you do certain things and it's good clinical practice that you would do these, but where they're going to put some components in place that you're going to have to demonstrate what it is that you've been doing. I know one of these areas that I dealt a lot with was in the medical audit, because the MQSA spelled out, what the medical audit is. There were a lot of things that were strongly suggested, but they stopped short of making it a requirement. Well, the problem with that was that it left facilities trying to determine what the best way to meet that recommendation would be. And so the medical audit all in itself is a very, it can be very simple, or if you're in a really large facility, it could be a very complicated process. So that is one component that's in the quality assurance, in addition to how you're improving process, how you're improving the process of communication of image quality, which is what we're going to be talking about today, and being able to, make that transition into documenting what your process is for establishing what's going to be acceptable and what's not unacceptable and how that is going to get communicated. Then, of course, the reporting of results was a big deal, 15 years ago when they came to us and said, okay, you're going to have to communicate results. Not only that, they gave us all these parameters for who, what, how, and when. We met all of those, but it was something that was one of those things where, oh my gosh, there's a lot of criteria here that have to be met. The consumer complaint mechanism has been in place for since 1999. Started inspecting on that, I think, if I'm correct, it was in 2002. Just that mechanism where you're inviting the public to be able to communicate what their complaints are so that they can be reviewed and resolved. And then we have seen facility closures, and I'll talk briefly about that. So the whole process of accreditation, when I first saw one of these charts many years ago, I had to laugh because I was like, oh, well, this is a complicated flow chart. But we've gotten it down to something that was relatively simple, where the ACR reviews your application. Not that the completion of the application is an easy process, because again, if it's an initial application, there's a lot of paperwork that has to be generated. And that's when all these initial qualifications for all of your different personnel come into play. But once you've been accredited and you're an established facility, then there are certain things that are going to occur. You're going to get inspected every year. There are things in place that you could have to participate in one of their random image reviews, and we'll talk briefly about that. But once you're up and running and you have all of your equipment, and the equipment issues aren't that great, where we're seeing problems are in the clinical images. And the majority of the program will be talking about the parameters and how we can improve those. So it is a process. Somebody in your facility has to keep up with all of the things that have to be done. But what we hope that has occurred, and one of the original intents of MQSA, was to develop a mammography team, a group of players that weren't isolated from one another, and that a program that had all of the major personnel groups participate, so that the overall image quality could be evaluated and then ultimately improved. So we have your physician, your lead interpreting physician is somebody that has to be named on your ACR application, and then you have all your interpreting physicians. You have a partnership with your medical physicist for the equipment. When I first started and did my first ACR application, and they asked me about my partnership with my medical physicist, I had to laugh because I just knew his name because it was on a piece of paper on a report that I kept in a binder in my office. So as we got started on our accreditation package, the physicist and I did become well known to each other, because there were a lot of questions that he had to help us ask. And it was true of the physician that participated also, and the technologist, and of course, then whatever accrediting body that you were approved through. So when we began to look at the overall program and the national statistics for MQSA, we know that every, and this is public knowledge, you can look these up at any time. This is dated June the 1st of 2017. Certified facilities, 8,741. When I started in mammo accreditation back in 1994, there were 12,880, I think, mammo facilities. So the number of facilities has declined over the years. And believe you me, there were some of those facilities that should have gone away, that couldn't comply. They didn't have the equipment, they didn't have the resources, they didn't have the support to be able to continue to provide mammography. But we have less facilities, but we have more units. So there are fewer facilities, but the facilities that are existing have different numbers of units. Deborah's going to be talking more about violations and inspection things. But level 1, which is the most serious of the violations, or the highest area of noncompliance, relatively a small number, but oftentimes those are the violations that require some sort of intervention or corrective action. Then level 2 violations and level 3. And we see that the percent of inspections that occur, and which is pretty amazing when you think about the number of units that we have out there with no violations, is 88%. So the actual statistics or report card, this is information that you can find on MQSA's website. So when we begin to talk about what are some of the reasons for clinical image deficiencies, one of the main ones, one we're going to discuss at length, is positioning. And the preamble to MQSA final rule emphasizes that all interpreting physicians are the final arbiters of the quality of mammo images. And although the technologist performs the mammogram, the responsibility for correct positioning is a shared responsibility between the technologist and the interpreting physician. This relates back to that team thing that we talked about, which was one of the original intents, that it would bring the technologist and the physician together to be able to ultimately improve the quality of mammography. So it's important that the interpreting physician communicate their satisfaction or dissatisfaction with the quality of the images they are provided. And sometimes that's difficult to do. And I know in some physician, it depends on your practice setting, but some physicians are reading remotely. They don't have, they're not on site. There's not that personal interaction between them and their technologist. These are scenarios where you have to develop a process to create that connection. And I don't want to make it sound like it's always an easy process, because it's not. But it is a shared responsibility between the interpreting physician and the technologist to determine what is acceptable and what isn't. Once you get started on that, and the interpreting physician applies the criteria to their images, and the technologist knows that those are going to be applied to the images, and those can be discussed and the differences worked out, then you get to the point where both sides will be able to see, hey, I don't think that's going to be acceptable. This is what I need to do to improve that image. But it is a communication process, and it's crucial to the first step in identification of the problems, and then, of course, an initiation of a corrective action if needed. We work with a lot of facilities that have had problems with image quality. And many times our role has been not only to work with the technologists in improving their positioning, but also in trying to improve the process and help to engage the radiologist in that process. So the mammographic clinical image criteria for accreditation submissions, this is what you have to have, and Deborah will be discussing this in great detail. But the mammographic images submitted for accreditation review must be negative, BI-REG category assessment category 1, Novodyne category 2, unless you have permission from the ACR, and no incompletes. If the facility only performs diagnostic exams and cannot submit negative images, they have to call the ACR. Deborah probably will mention that too, because they're in a cancer facility. They don't do a lot of screening mammograms. Most of their procedures are diagnostics, and they're non-negative. So they have to ask for an exception. Cases must be example of your facility's best work. When that seems like that goes without saying, but the reality is it depends on your patients and your patient population and your volume, and it may not always be as easy as saying, oh, just give me an example of your best work. It depends on your patient population. Sometimes that's difficult, not impossible, and something we're going to discuss, but you know, it should be an example of the best work. Images must be from actual patients and must have been formally interpreted by a physician. In other words, you can't use a model that would come in where you would make the exposures. Images from models or volunteers are not acceptable. Life would be wonderful if that's the case, but not so. Not a real measure of mammographic quality. The complete breast must be imaged in a single exposure on each projection. Any breast tissue missing is considered an automatic failure. Again, selecting the images and critiquing those images and having the physician, the technologist, maybe some more than a couple of people look at the images and critique them is important. Digital images must be as close to true size as possible with no minification or magnification. Both film screen and digital images must be labeled with the MQSA required identification information. I've done a couple of accreditations in the past where the facility did not pass because they didn't have the required identification on their films. And boy, that's a hard pill to swallow. When you have to back up and do all of that, and it had to do with required identification. The lead interpreting physician must review and approve the clinical images that are submitted. Electronically submitted images must be processed and marked for presentation purposes. So there's some of the fine line of once you select your images that you're going to be able to submit. And in reaccreditation, you know, you do get to select your images. Now, if you get into a situation where you're in a random audit review or an additional audit where they're asking you, they've seen some things on your initial clinical images that they were uncomfortable with, and they may do an AMR, an additional medical review, and they may say, we want films from this date to that date. So clinical images and image quality, the interpreting physicians shall follow the facility procedures for corrective action if you end up in a situation like that when the images are poor quality when asked to interpret them. There should be a procedure in place to follow when images do not meet the established clinical standards. And this is the process that they're talking about in some of the EQUIP initiatives that they want to be documented and to verbalize. I don't want to say a policy because really, you know, unless it's a process that people are following, anybody can write a policy, but they want to know what process that you're going to use to make sure that if the films don't meet this agreed upon criteria, that how that's going to get communicated. So if a screening mammogram is read the same day taken, if the images are not up to standards, then that screening mammogram should be read with a tech repeat recall result and a BI-RAD 0. All right, so we're talking about failures. Again, I said Deborah is going to be discussing these in much greater depth because the number of failures that primarily are because of positioning, exposure, and then compression is number 3. So we'll be looking at positioning errors, exposure errors, and compression errors. She will also talk about sharpness, contrast, motion, and point out the required exam identification. Inadequate pectoralis major muscle in the MLO. She'll show you examples of these using images and multiple examples, so to help you be able to say, yes, that's what it is, and be able to go back to the technologist and say, this breast is sagging, you know, it is an inadequate image, this is what you need to do on this image. Now, the technologist should know how to troubleshoot their images, but hopefully if there are problems and you're dealing with positioning deficiencies, technologists are going to be required to do some hands-on training. And that hands-on training is going to address each one of these deficiencies. So if they did not know how to or how to correct a sagging breast on an MLO view, then the hands-on positioning training is going to provide them the tools they need to overcome that particular deficiency. And there are techniques and tools. Every patient is different, and so you're customizing the procedure each and every time that you do this, but there are many techniques that a technologist can use to overcome whatever deficiency that there is in the image. And if that can't be overcome, that has to be communicated and documented to the interpreting physician. I used to tell students that I trained, the physician can't interpret what you can't image. And so you give him something that's an inadequate image, then he can't do his job. This is truly a team effort. In 2015, the American College of Radiology, which is the largest approved accreditation body, found that of all their clinical images, which were deficient on that first attempt at accreditation, that 92% were deficient in positioning. This is not news. This has been from the get-go, positioning and training, and really something that that we're trying to address. And a lot of the continuing education opportunities for technologists are about positioning, but unfortunately, a lot of them don't have that hands-on component. And so when there are deficiencies and in a corrective action plan, they're requiring technologists to do additional training. you will see that it is hands-on. That means that somebody has to be there to be able to do it. It's like driving a car. You don't learn to drive a car by watching a training video. You actually have to put your hands on the wheels of the car to be able to determine that. So the positioning problems are significant, and we know that they're there. In ACR accredited facilities, 79 of all unit accreditation failures in 2015 were due to positioning. I think you get it. We see in Texas, 100% of their clinical image failures in Texas had to do with positioning. So remember that ACR conducts random film checks. MQSA requires these random clinical image reviews to monitor and assess the compliance. They select 300 facilities each year, and they evaluate the image quality, the phantom image quality, and the quality control. So your facility could indeed be selected for one of these. I was told, and there are some additional image reviews that I understand that aren't so random, that they are initiated by a complaint. So if you're one of the facilities that gets to participate, but they do select 300 facilities each year. Okay, so in order to achieve and maintain proper positioning, both training and communication are essential. And so if you're in a position where you have deficiencies of some sort and they are positioning, then you're going to be involved in developing a corrective action plan. And that corrective action plan, whatever it's going to be, should address both the training for the positioning and the communication and how you're going to improve that process. I have seen some things in the last year in our consulting business where we assist facilities if they have some sort of problem. I've seen an increase in the number of ones that are requiring corrective action plan that have the hands-on, and each one of those has this component that talks about the communication process and how you're going to document that, and how we're going to talk about the process of the communication between the interpreting physician and the technologist. In QSA Insights, this actually came from that article, in saying that this is one of those quality assurance components that they talked about in MQSA from the get-go. But as the process has progressed over the years, that they're focusing on. So let me introduce you to the person with the clinical expertise to be able to share with you today. Deborah Thames is a technologist registered in mammography with 22 years experience. She's also registered in quality management. She is considered a mammography specialist. She is one of our consultants here at Advanced Health Education Center. She teaches our initial mammography training program for people that are trying to meet those initial requirements for training in mammography, our 40-hour program. But most importantly, Deborah is a clinical specialist. She is full-time technologist, mammography technologist at MD Anderson Hospital here in Houston, Texas. She is currently a technologist that is working on the mobile unit. So she has extensive experience in the clinical and the technical components of mammography. So she'll be sharing her expertise with you also. So thank you, and Deborah will be with us shortly.
Well, thank you, Peggy, for that introduction. It's a privilege to be here today, and I hope that all is well and that these examples will help you. So thank you very much for having me today. Now, positioning, as we know, is the #1 deficiency. When you get a deficiency letter or a failure when it's the second time. But these are the percentages, they're all in order, that causes the clinical image failure or deficiency. So positioning is the number one, compression, exposure, sharpness, contrast, artifacts, labeling on the image, and then noise. So these are all in order. And positioning has been the number one failure in the 8 categories probably the whole time in the history of MQSA. Now, the most common positioning errors are poor positioning of posterior tissue both in the CC and MLO views, sagging of the breast on the MLO views, inadequate amount of pectoralis major muscle on the MLO view, excessive exaggeration on the CC view, skin folds both on the CC and MLO view, other body parts projected over the image. I know it sounds crazy that personnel would turn these in for accreditation images, but it's happened. Non-standard angulization on the MLO must be between 30 and 60 degrees to call it an MLO view. Posterior nipple line measurement not within 1 centimeter on the CC and MLO view. I'm going to teach you how to measure where to start and end on both images. And breast position too high on the MLO. Therefore, the TEL is not image. And that's very important to see, especially in the telespense. Remember, the breast tissue superiorly starts at the second rib. So on the CC view, let's go over that first. Pectoralis muscle is visualized usually about 30-40% of the patients according to the ACR manual. But with the new positioning skills, when we've evolved with these new tricks, new equipment, we can get pectoralis muscle about 60% on the CC view. Make sure to measure from where the nipple attaches to the breast all the way back to the posterior tissue on the image, and not at the tip of the nipple for P&L measurements. It has to be where the nipple attaches to the breast. Medial versus lateral tissue, so the nipple has to be perfectly centered. Our nipple does talk to us. That's why it's so important to have nipple markers at your facilities. Not only does it help the radiologist, but it mainly helps the technologist in their positioning. Have the end of the parenchymal pattern laterally on the image to where, of course, we know when breast cancer can grow, it's going to happen in the parenchymal structures of the breast compared to the fat. Nipple must be in profile for your ACR in both views. It's good to have the nipple on all the views when you go to turn them in. You know, ACR does recommend in one view only for your just everyday standard, but when you turn in ACR, they really like all the nipples to be in profile, because we know the large breast, the nipple tends to fold underneath it. Now you look for variation in nipple location, but it must be centered because it presents most tissue possible medial and lateral. Now on the MLO view, your medial lateral oblique view, we want to see pectoralis muscle all the way down behind the nipple. They call that the posterior nipple line. Not the measurement, but the line. Muscle should be wide superiorly with the convex border. The IMF or inframammary fold seen on the image must be present and without folds, and has to clearly be visible, not an imagination line. I know it can get darkened out, especially on dense breasts because your KVP jumps way high, but it has to clearly be visible to them without having to window or level, which they can't anyway, but it has to clearly be visible to them. Your retroglandular fat included from the tail down to the IMF. They must see it from superiorly, what we're talking about, the tail of the breast superiorly, all the way in the back down to the IMF. If it isn't clearly seen, then the parenchymal patterns aren't all visualized. And look for the variation in nipple location, and nipple must be in profile for the MLO. Now your breast parenchymal pattern MLO must be horizontal in orientation. If it's going vertical, that means the breast is sagging, so they're going to look at that. So in order to have the parenchymal patterns horizontal, the technologist really needs to hold the breast up and out. And definitely no sagging on the breast. The bottom of the breast must be horizontal in orientation. So let's go over each of the 8 categories that the accreditation body scores. Now on this image, you could see here's where the nipple attaches to the breast. They're going to draw an imaginary line all the way across. It's a horizontal line, and the nipples have to perfectly meet on those lines. They're going to look for the pectoralis muscle here and all the retroglandular fat, which kind of should make a circle. They're going to see if the medial tissue's on there without folds and the lateral tissue on there without folds. They really want to see the end of the parenchymal pattern here. That's what we're talking about laterally. Sometimes patients' breast tissue is so dense it goes up into the talus spence where you can't visualize the talus spence on the CC. So it's really good to have the end of the parenchymal patterns in there. The structure should be well separated with good compression. As you can see here, there's a tiny, tiny fold medially. They don't want to see that. Maybe they're not going to give you a deficiency, but they will mark it on the papers that they give you. So these aren't bad. They're pretty good. They want to see a symmetrical pattern. They want to be able to draw that circle all the way around when they put both images together. So here's some CCs as you could see on the images. And here, once again, they're going to draw a line all the way across. And the right CC, it's not perfectly centered. It's not bad, but it's not absolutely perfect. So it's pointing medial, which means it's missing retro medial area posteriorly. You want to see the corner of the breast up there on the image because that really means you have good medial tissue. If you don't see the cleavage, that means that they're looking to say, hey, did you miss medial tissue or not? And you can see he has some intramammary lymph nodes here. This patient's really very, very fatty. She really doesn't have any end of the parenchymal patterns here because she's almost entirely fatty. So these are good images. The muscle shows. It's very easy to get muscle on this patient, obviously. The nipples aren't off centrally that bad, just a little bit on the right CC. But these would be good images to send in for the ACR or your accreditation body. This would be a BI-RADS 2. Now in this patient, once again, you draw that imaginary horizontal line all the way across, and the nipple isn't perfectly centered, it's just millimeters medially here. But you could see, you could draw a circle here. It's very nice. There's a few tiny little skin folds, but that's not anything that's going to give you a deficiency. But the end of the parenchymal pattern on both sides are in the images. It's absolutely beautiful. There's retroglandular fat here, which is very nice. Good medial tissue, good lateral tissue. And these are an example of good images to send. No, we don't see muscle, but as long as your posterior nipple line measurements meet a requirement on the MLO, these would be a good set to send in for accreditation. Now here's very, very beautiful MLO views. You can see superiorly there's wide muscle with the convex border all the way down to your P&L line, your posterior nipple line. If you draw a line straight back from the nipple, you can see its posterior nipple line. It's beautiful. Very wide superiorly. They're looking for that convex border with the muscle pattern to show that the patient was leaned in and down. The nipples are perfectly in profile. You have beautiful IMF here. The patient has a mole with mole markers. That's fine. You can put mole markers on accreditation images. This is a scar marker, BI-RADS 2, benign. They really don't want patients who've had a benign biopsy, but if that's the only thing you got, that's what you could send it. But remember, you need permission. See up here in the tail of the breast superiorly, there's a few little skin folds. It's not tissue fold, it's skin fold. Your technologist can try and get those out with her fingers when she's positioning, and to twist the arm posteriorly so the arm's not sitting on the detector, it's behind the detector. But you can see the structures in the breast. The parenchymal patterns are horizontal. That's what they're going to look for. The bottom of the breast is horizontal. You can see how pretty that is. The tissues are well separated. They're sharp. There's no delineation in the image. There's very good compression, good instructions for the patient's breathing. So these are beautiful, beautiful accreditation images. Just one or two little tiny things like these tiny skin folds up here or a little fold down here, but they aren't going to give you a deficiency for it. They'll just mark it off. Remember, a deficiency is where you truly don't pass the first time. It's not a failure yet. It's called the first deficiency. So these images are absolutely beautiful to turn in for accreditation body. So let's look at this MLO view here. There's a few things we're going to talk about. Number one, the nipples in profile. Luckily, they had a nipple marker on because you would not know where the nipple is here on this image. There's different post-processing algorithms per different manufacturer. So not all images look the same when they're post-processed. So yes, I know that it's you can window and level to be able to see the nipple, but here they can't see it. So as you see, the bottom of the breast is pretty horizontal, not bad. But when you go up into the IMF, you can see it goes up and down. They don't like that. They want to see more of a horizontal curve here instead of like a backwards V. They don't like that. Plus, there's a little fold here that the technologist probably created by pushing up and out on the breast too much. Most of these folds in the axilla are created by the technologist. Just like this little fold here, the technologist didn't fold the arm back of the detector to where it's not going to be crinkled here. The muscle is wide. There is a little convex border and is down to the level of the nipple. So that's a good portion when positioning on this patient. You can see a few lymph nodes here. But there's like 4 issues here. Number 1, it goes up. Number 2, there's an air gap fold here. Number 3, there's a fold from the breast being pushed up. And number 4, there's a fold in the axilla from the arm not being twisted back. When you look at the comparison of the same patient, different technologists, you can see it's better horizontal. Even in the IMF, it's more horizontal. The nipple's perfectly in profile. You can see there's no fold here created by the technologist. And there's a tail of the breast without a fold here. The muscle's more wide with the convex border down to the level of the nipple, your P&L, right here. That's beautiful. This is a very acceptable image for accreditation, there's a tiny little fold here in the IMF, but there's just one thing you really can comment on, and that's not even hardly there. So do you see the difference in positioning and what you want to turn in for accreditation body to be able to state your facility does beautiful, great work? So let's talk about the P&L measurement, not the P&L line where you have to meet muscle, just the P&L measurement between the CC and the MLO view. This is a must. You must pass this. They're very strict on this measurement between the CC and MLO view. Even if it's 1 millimeter short, they will possibly give a deficiency marks on this. So remember, measure from where the nipple attaches to the skin of the breast. CC, you measure from where the nipple attaches to the skin all the way back to the image. And on your MLO view, you measure from the nipple to the muscle, even at a 45-degree angle if needed. The MLO, they want muscle to the posterior nipple line, remember? But if you can't meet that, they will give you a 45-degree angle. So here's an example. All right, let's learn how to do the P&L measurement. This is, like I said, very strict. There's no tricking them when it comes to this. Not that you want to trick them, but they are very wise about this measurement. So you measure from where the nipple attaches to the breast all the way to the back of the image. So let's just say it's 10 centimeters. And then you measure from where the nipple attaches to the breast all the way back to the muscle at about a 45-degree angle. And let's say that measurement is 11. So that would pass. It's within 1 centimeters from each other. So the lower number, if it doesn't pass, that means you're missing posterior tissue on that image, whichever image it would be, whether it's CC or MLO view. So once again, measure from where the nipple attaches to the breast all the way back to the image, and then where the nipple attaches to the breast all the way back to the muscle. Once again, here's another example. From the nipple all the way back to the image, say that's 9 centimeters. From the nipple all the way back to the muscle, say it's 11 centimeters. That would not pass. That means that you're missing posterior tissue on the CC view. So those measurements are called the P&L measurements to be able to make sure that you're getting enough tissue on both views. So here's another example. On the left CC from the nipple all the way back, and on the right from the nipple all the way back. And as you can see, they got a little bit more on the left from the right. Well, they're going to look at that also. Not every breast is larger or smaller than the other, so they are going to compare each breast to one another also. So you can see this is 13.2 and 13.8. It's within millimeters, but you could tell that there's some tissue missing on the right CC. Here's the MLO view. So measure from where the nipple attaches to the breast to the muscle. Same thing here. And you can see it's 14.1 and 14.7. So on the right breast, 13.2, 14.7, that fails. That fails the measurement, and they will mark you off on the paper for that. On the left side, it was 13.8 and 14.1. So that's within 1 centimeter. So this passes, this side does not. So what does that mean? You're missing tissue. Let me go back here. You're missing tissue on the right CC posteriorly. So they will mark you off on your paper on that. You're going to get marks you're not going to have the perfect image. You will get some kind of marks, but when you start getting 4, 5, and 6 marks, they're going to give you a deficiency letter, and they're going to want you to redo it. So you try and do the very best with the least minimal. Now let's look at these positioning on this case. There's a little fold laterally here. They don't want to see any folds. The nipples are perfectly centered. I like that. But you could tell on the right also it's very hard to see if you got good medial tissue compared to the left breast. So I would have definitely redone that right side if I was turning it in. Now on the MLO views, they're absolutely beautiful. Of course, this is a fatty case. She's entirely fatty. The muscle's wide with the convex border down to the level of the nipple. On both sides, it's beautiful. The IMFs are beautiful, open, without folds. The bottom of the breast is horizontal. The nipples are in profile, and there's no folds up here. So these are absolutely beautiful. I can see why they turned these in for the ACR, but it did fail in measurement. All right, let's look at another example here. Here's the left CC. Measurement from the nipple all the way back, and the right CC from the nipple all the way back. And it's 11.3 and 10.6. So that's kind of a big difference on the CCs, one compared to the other. So let's go to the MLO view. And as you can see, the right is 12.3 and the left is 12.2. So that's not too far off at all. So you could see that these failed on the left breast because it's 10.6 and 12.2. So this is a failure in measurement. Don't send it in. Even you got to find something better. The technologists should have realized that when they took the image that the muscle was shortened here. It's not as long as it was on the other side. So I would not send these images in. Plus the IMF isn't on there clearly. It might be on there, but it's darkened out from the post-processing and the KVP. So I would not have sent these in. And I would not recommend that. All right, let's talk about inadequate amount of pectoralis major muscle on the image. You can see here it's very wide superiorly, but it's concave in pattern. They do not like that. They will give you a mark on your paper on that. Now the nipple is beautifully in profile. IMFs on there pretty. The bottom of the breast is horizontal. Parenchymal patterns are horizontal. It's very, very nice. But they will mark you off on the pattern. It's inadequate. There's not enough muscle. Plus they want to see that convex pattern, not a concave. Use the correct size paddle. We know with digital equipment the detector's fixed, and so you're going to use small paddle or large paddle. We can see here the nipples in profile. The muscle isn't that great. It is wide superiorly, but there's not enough coming down. Also, there's no IMF in the tail of the breast cut off. Why? Because the technologists used the wrong size paddle. You can see here in this image, same patient. There's more muscle. It's a wider pattern. There's beautiful open IMF. The bottom of the breast is horizontal, nipples in profile, and the tail of the breast is on there. Here, you go to the middle of the image, and it needs to be 2 centimeters above the nipple to be able to make sure you don't cut off the tail of the breast. But here you can see it's truly 2 centimeters above the nipple. That way you have the tail of the breast in here. This is wrong. When you have a medium breast, your technologists need to learn, always go to a larger paddle. Now here's another example. So you go to the center of the image. They are about 2 centimeters above the nipples, so they've centered it correctly. But once again, they put the arm in front of the detector instead of the back. You have an air gap here because of the fat of the arm, plus you have a crease here. The muscle isn't real wide superiorly. It does have a convex border, but they want to see more muscle than that. Here's the IMF. It's clearly on there, but there's another fold down here. There's an air gap. You see this black air gap here? That means that the skin is not touching the detector when you see that. Nipples in profile. So yeah, this isn't the best to send in for accreditation. Now, these images in comparison were done a week apart. This patient was trying to get diagnosed. She had some palpable areas, but you could see this is in America. This is very scary as far as quality goes. I know technologists can be afraid at times when someone has palpable and they're in a lot of pain to give compression or to be able to, for the patient to allow them to do good positioning because they might be distraught, feel like they have cancer when they come in with palpable. So they're not listening, they're not paying attention, the patient, and it's kind of hard to direct them to be able to do what you ask them to do. But it's very imperative. It's very, very imperative. So you can see here the nipple's not in profile. There's no IMF. There's a large fold up here in the breast created by the tech. And also there's hardly any muscle on here. Compared to the positioning over here, same patient, about a week apart, different technologist. You can see the difference. This technologist gave the patient good instructions. They positioned beautifully, wide, superiorly, muscle pattern with the convex down to the level of the nipple. You could draw a 45-degree line here. You can see the IMFs on here, and it's open. There's you want to make sure to get the fat from the clavicle posteriorly all the way down to the IMF. That's very, very important. That's what they're going to look for. So you can see the quality of positioning. You wouldn't think this would even happen in the United States because of our good equipment, our wonderful education that we have a privilege to be able to learn from. So these are beautiful accreditation images, absolutely beautiful. We know the densest part of the breast is anterior, central, and going lateral, plus it's superior in the breast. So if you look at the center of the image, it's about 2 centimeters above the nipple. Your technologists have photocell markings on the paddle. The only ones that are manufactured that do not are GE, but if you have any type of GE machine, just draw a little black line in it on the paddle on the inside, and that will help the technologist be able to see where the center of the image is. So the muscle on both sides is wide superiorly with the convex border down to the level of the nipple. The parenchymal patterns are horizontal. The IMFs are clearly on there. There's no folds in the IMF. The nipples are in profile. And this is just absolutely perfect images for accreditation purpose for dense breast. You can't get any prettier than that. There are a few little wrinkles here, but they aren't going to mark you off for that. These aren't bad. This is wide superiorly with convex border down to the level of the nipple. The bottom of the breast is horizontal. The parenchymal patterns are horizontal. You can see that this is milk of calcium here. So it's held up and out, very nice. They got the tail of the breast up here. You could tell the center of the image right here is 2 centimeters above the nipple. So this is beautiful, but it's missing IMF, and they will mark you off for that on the report. Otherwise, it's beautiful. So that one major part of the anatomy is gone, and they don't like that. They do not like that. All right, let's look at these images. Same patient, different technologist. You can see the different muscle patterns. Well, how'd that happen? It's the same patient. How'd they get different muscle patterns? Well, number one, the technologist put two different angles on here possibly. This could be like 40, this could be 30, or something different, or to the other extreme. It's hard to tell if you're not in the room to see the angle, but they're definitely different angles in the muscle, in the detector that the technologist did when she was positioning the patient. Also, you can see the nipple is profile here better than here. It's barely in profile. The IMF's on here. There's a little fold here. You can see the black air gap where the skin doesn't touch the detector. There's a little fold, but at least it's on there. Here, it's absent. So we know she's missing posterior tissue on this patient. She's missing a lot of posterior tissue. Plus, the contrast is better over here compared to here. There's probably more compression here. So you could tell that big difference in the positioning, the angle, and the different skills of the patient. All right, you can see here, these are beautiful images. I would pick these to send if they didn't have the clips in there, of course. They really don't like to see biopsy clips when you send it in. But otherwise, they're beautiful. Wide superior muscle, convex border down at a 45-degree angle. It meets 45-degree angle, even though it doesn't come all the way down the nipples. The breast parenchyma patterns are wide, separated. You can see structures. There's no summation. Beautiful IMFs. They're clearly seen. The nipples are in profile. This one not as much, but it's not bad. It's still in profile. So if these didn't have the clip, I would definitely send something like this in for accreditation. It's very nice. The parenchymal patterns are horizontal, very well separated. Beautiful, beautiful positioning. Another problem are skin folds. That maybe looks like a vessel to some technologists, but you can clearly see it's an air gap here. So I make sure and look for those and teach the technologist the difference between vessels and skin folds, especially with these patients that are getting surgery done. They can lose large amount of weight from one year to the next, and you can tend to get more skin folds with patients like that. Plus, you want to draw that horizontal line to make sure your nipple is centered, and it's not, it's over exaggerated. So then you're missing all this medial tissue over here, plus the end of the breast isn't even on the image. They're going to look at that. So there's a lot of issues here with this image, with the skin fold, the nipple not being centered, the whole breast not even being imaged. It says it's a CC view, but we know it's not. This clearly is not a CC view. It's a XCCL. Skin folds, also in the MLO view, you could see in the muscle, it's tightened. Why? Well, one thing is maybe the patient's hanging onto the bar and tightening it with the death grip, or the detector's too high and it's pulling the muscle up. So there's few different reasons why you get folds in the muscle. Also, there's skin folds up here. They don't like to see that. The nipple is in profile. There's a little IMF on here. This patient is very, very thin, so your angle needs to be higher, like more steeper, 55 degrees or so. To be able to accommodate. We know that the angle depends on body habitus. The more shorter, the more heavier the patient is. You want to use less angle, like 35. And then the taller, the thinner the patient is, you want to use a steeper angle, like up to 55 or 60. Nipple not in profile. That's not good for accreditation images. Like I stated before, you want all 4 views to have the nipple in profile. Plus, this patient's very dense, very thick, so you have this post-processing algorithm defect where it looks like a breast inside of a breast. But you want to make sure and have the nipples in profile. Here's a pretty image. Medial tissue, muscle. This patient's very fatty, But you can see here, the nipple's not in profile. It's folded under. There's a BB. That's how we know. If you didn't have the nipple marker on there, you wouldn't even know where the nipple is. There's a little air gap from the tape because the nipple is so folded under. So if you're doing patients like this daily, that's fine. Just do a nipple in profile view. But for accreditation, no. You don't want to send an image in when the nipple's not in profile. Other body parts over the image, this was sent in, I promise you. You can see the nipples here, straight line, retroglandular fat, muscle, the end of the parenchymal pattern, but you could see that. I took this image. This is me, Deborah Ann Thames. You have to watch the patient 100% of the time because you have them positioned, you turn your back, you go back to make the exposure, and the patient looks down at the breast. They do this all the time. So I started walking backwards to the console to make sure and tell the patient, no, don't look down, don't look down. Keep your chin up because they always want to look down and see what you're doing. So it's really easy for the patient to get other body parts in the image, but you have to watch them 100% of the time. It's like sometimes babysitting. You just cannot keep your eye off them because they're going to move on you. Here, there's neck. There's the other breast in the way down here. This is camel nosing a little bit. If your breast goes up and then down, it's called camel nosing, to where it does truly look like a camel's nose. So you want to make sure and have this horizontal at the bottom. The nipple is in profile here. Here's a CC view. The nipple is perfectly centered. They don't have a lot of retroglandular fat. I wouldn't send that in, but look what you have here. You have a nose. These are your nostrils where the patient wants to look down. Even when you give good instructions to tell the patient look up and out, sometimes they just don't do it. So this isn't a bad image. I'm going to point out a few things that are very subtle. But I like the retroglandular fat. I like she has muscle. The nipple's in profile. The nipple's perfectly centered. They brought the other breast up here to show they got good medial tissue. But look over here laterally. Just a tiny bit of the shoulder. Just a tiny bit. This would be a good dense breast to send in. If they, of course, could have got the shoulder out a little bit more. So if your techs see this, it's a good accreditation image send in. Go back and repeat the image. So let's talk about the breast too high on the receptor. So you're going to go to the center of the image, draw an imaginary line, and this needs to be 2 centimeters above the nipple or so. And this is only about 1 centimeter. What's that telling me? They cut off the top of the breast. They cut off the tail of the breast, which many times we have seen breast cancer up there. Remember, the second rib is where the breast starts superiorly, or at the clavicle. So the top of the breast is cut off. There's a fold here at the IMF. The IMF's on here clearly, but there's an air gap. It's not touching, the skin's not touching the detector. So you can see this huge air gap here. That's not good either. Now compression, this results in, if you have inadequate compression, it can give you poor separation of parenchymal densities, non-uniform exposure levels, and patient motion. So compression is very, very important no matter what breast modality that you're using in mammography, whether it's film screen, whether it's 2D imaging or tomosynthesis. Compression is very, very, very important. You can get poor separation of these structures to see if there's any tiny subtle abnormalities in between these structures because of lack of compression. You can get more patient motion. You can see here this motion is all over the breast. It could be very subtle. It could be regional, and it can be over the whole entire area. Sometimes technologists get in a hurry where they're not checking your images very good, but they need to take their time. Also, they can zoom in on the image to check for motion. I would encourage your technologist to use the zoom button or the magnification tool to be able to see if they think there's motion, that they can use that tool. But compression does reduce patient motion. So here's another example. The same patient. These two images were taken at 2 different times, but the same year. So can you see a little difference in either one compared to the other? They're both positioned pretty good. The nipple's not perfectly in profile here as it is here. Good medial tissue. So I'll give you a minute to look at it before we talk about it. All right. So one of these images has a little bit of motion, just a very, very subtle. And as you can see, it's this image. Well, when it was magnified, zoomed in, what do you see? You see a group of calcifications here in the sharper image, and here you could tell there's delineation of this large coarse calcification, but you don't see the tiny calcifications here. Why? Because they're blurred out. So what was this? When this was biopsied, this was a small low-grade DCIS, but it was missed here. Now, if the radiologist would have maybe let it go, not called the patient back, or maybe not even seen this subtle little bit of motion, the cancer maybe could have grew next year into an invasive cancer. We don't know, but we don't want to chance that. We don't want to chance a patient getting invasive cancer from non-invasive by not finding it early enough. So it's very important, as we know, mammography to find breast cancer at the earliest stage possible, where the patient doesn't have to have such extensive treatment. So yeah, that was very subtle, and it's a great example of missing cancers, where the tiny cancers can be missed in motion. So let's talk about more characteristics of the images. What about your contrast? You can have inadequate contrast or excessive contrast. Contrast image shall permit differentiation of subtle tissue densities. And you must watch the window leveling and width, especially if you don't have a post-processing algorithm that you can change after you take the image. For instance, GE has premium view and fine view. They're post-processing algorithms that after you take the image, you can switch the local contrast to change it, which is a really neat app that you can do with the equipment. Not all equipment has that. Now we know in film screen our contrast was controlled by your KVP and your emulsion and your chemicals, but with digital it's your contrast is controlled by your lookup table, your LUT. So it's very limited per computer, and each manufacturer has different computer algorithms. That's why your contrast looks different from manufacturer to manufacturer. So you can see here, this contrast is very poor. It's too light. You want to see blacks, whites, and grays, but it's not even penetrated here. So for one, the KVP is too low. And number two, there's probably poor compression. And there's an air gap here. There's folds here. The positioning isn't that bad, but the contrast is very poor, and this would get a mark on your report. Now noise, visually striking model in the image, noise limited visualization of detail, it can get in the way. We do check noise with your contrast to noise ratio and your signal to noise ratio, so it's part of the quality control program. And noise in the image can not obscure breast structures or suggest the appearance of structures that really aren't actually present, like calcifications. It can look like calcifications, but it's not. And it's all created by noise. And if you get noise, make sure and tell your technologist to increase your mass. That can decrease noise. Now, artifacts, there's many different kind of artifacts. Um, Difference between film screen artifacts, digital artifacts, tomo artifacts. So they all have their different categories with patient artifacts, uh, processing artifacts, positioning artifacts, storage artifacts. So there's many different kinds, but just make sure and check your images before you send them in. They don't have any kind of artifact on them that they can mark off on the report. Like punctate or lint if you use film screen, scratches or pick off with film screen, roller marks, grid related artifacts, both film screen and digital. Hair, it's very subtle, but hair shows up, especially if it has, if patients have gel or hairspray or wigs. Like I work at a cancer hospital, so a lot of our patients have wigs. And not that they have breast cancer, they might have ovarian cancer, cervical cancer, so they have wigs on when we're doing their screening mammograms. So we have to be real careful with wigs because that hair really shows up very, very well. What about deodorant? It's very subtle, and that's definitely an artifact. Image handling artifact with film screen, image fogging, poor screen film alignment with film screen, dead pixel artifacts with digital, lag or what's called ghosting with digital, streaking is very common, and misread columns is common with digital. So there's multiple different artifacts that you could see. Now this is grid related artifacts. It didn't oscillate correctly. You could start seeing lines on the images. Hair, this is very common type of artifact. Deodorant, see how subtle it is? You definitely have to magnify to see the deodorant. So you ask the patient, all right, do you have any deodorant on? They say no. Did you put any deodorant on today? No. Well, guess what? They did yesterday and they didn't take a bath, so it's still on there. So we try and have all our patients wipe, no matter if they put deodorant on or not. It can even get under the skin, especially if patients wear it very heavily. They cake it on every day. We've seen it get under the skin. So you see this image here. It's not bad. Nipple you can't see. There's no nipple marker. The bottom of the breast cut off because she's very, very large, even for the large detector. So you don't want to send in mosaic imaging. But I'm just showing you this image because you really don't see anything here. But when you zoom in on it with your zoom factor, look, there's tiny, tiny pieces of deodorant because it has zinc and aluminum in it that can show up on x-rays. Image fogging, if you have film screen systems. Skin folds, we talked about that a little bit before. This is not a large vessel. Plus you could see motion. There's not separation of these structures in the breast. This is a very, very poor image. Let's look at some digital artifacts. These lines here, what are those caused by? Well, in this case, it's a face shield. The face shield got pushed in a little bit on the CC view. So when the tech went to do the MLO view, she didn't notice it was pushed in and it got in the way. So the technologist really has to be careful of the face shield. So it got put back in place. Both images were retaken, which are pretty good images. Muscles wide superior convex border down to the level of the nipple. Nipples are in profile. IMF, there's a little fold in the IMF here, but they're beautiful images. All right, what's this? When you see a line go straight across and a line going down, that means that the technologist accepted the image before it's totally processed. So this can be a common artifact. It's just a processing artifact, and it's caused by the technologist mostly. See miscollimation line here. It's misread line. It's not read out. That white line should not be there. Hair. Look at it here. There's hair. It's very subtle, kind of starts looking like vessels, but that's hair. The nipple's beautifully centered, though. I like that. This is a beautiful image. A little bit of skin fold, good muscle, nipples perfectly centered. But what do you see? Hair. See how subtle it is? Very subtle. Another category is exposure. You don't want to have underexposure, overexposure. You want to have good penetration of the dense areas in the breast. You don't want to have excessive penetration, especially in the radiolucent areas, fatty areas. An exposure level should be adequate to visualize the breast structures from the chest wall all the way to the nipple. That's why we have these post-processing algorithms in digital equipment. So you can see here this image is clearly underexposed. It's very gray. This isn't penetrated well here. So they'll mark you off for exposure on that. This is overexposed. You don't see any fatty tissue. You don't see any structures in the back. There is muscle here, but it's black and white. The contrast is way too high. It's beyond. We want high contrast, but it's beyond high. An adequate penetration of dense breasts, the KVP should have been higher, so it was very poor contrast. It's not penetrated well enough. They have good end of the parenchymal patterns, retroglandular fat. The nipples are perfectly centered, but it's not good penetration. So let's talk a little bit more in detail about compression and how very important it is. Compression shall be applied in a manner that minimizes the potential obscuring effect of overlying breast tissue and motion artifact. So these are the benefits of compression in each breast modality with mammography. The number one benefit of compression is a more uniform thickness of the breast because your contrast is going to be better. If it's a more uniform thickness, it's not thicker in the back compared to the nipple or the front, it's going to give you different, better contrast. It spreads the tissue to lessen superimposition to find those subtle little small abnormalities. It reduces radiation. It improves your contrast. It improves sharpness. It brings the breast closer to the image receptor, therefore there's less geometric blurring. It reduces motion. So compression is a must and should be, in my opinion, at least 15 to 20 pounds on each patient to be adequate. Please look at the breast compression on your image when you're reading. If there's any question that there's not enough compression, just look at it. The pack should be able to show it, and the indication in number. Summation is indicating the patient should be called back for repeat images to have better compression. If you have a GE machine, GE 2000D, GE DS, or GE Essential, now there's the new GE Pristina. If you have any of these machines, the compression is read out in decanewtons, which converts to 2.2 pounds per decanewtons. So you want 8 to 10 decanewtons per patient to meet that 15 to 20 pounds. In pack systems, some readouts are NT, what's Newton. So if your PACS reads out in Newton, you want at least 85 to 95 newtons to equal about 20 pounds of pressure to separate the tissue. There's no regulations that state you must have this amount of compression. Now there is a quality control test that you do on the equipment. It tests the equipment to make sure minimum is 25 pounds of pressure and maximum is 45 pounds of pressure. That's just testing equipment. That's not saying that's how much the minimum or max that you have on the patient. There's no law on compression with limits. But my experience, I feel that the technologist should get at least 15 to 20 pounds on each patient on every single view. So here's an example of the same patient, one is a real good compression and the other isn't, if you could tell the difference, look at it and tell me which one do you think's better compressed compared to the other. I think it's a little obvious. This has more compression. It's sharper. You can see here, these aren't separated as well. The contrast is better. This stands out better. This, in fact, looks a little blurry, maybe. You can see this isn't well separated compared to this. And there might even be something here medially. We don't know. You can see there's a calcification here. You can't tell there as well. So you can see the extreme difference from very good compression to just not adequate compression. It changes everything. Here's another example of good compression and not good compression. Can you tell which side of the same patient, different tech, gave better compression? All right, you can see here it's shadowy, it's summation, it's not compressed as well. It doesn't look sharp compared to here. You could tell that these are more separated anterior than it is here, and the contrast is better. So there's many different factors, as we talked about, with why compression is so very, very important. Let's talk about sharpness, poor delineation of linear structures, feature margins, microcalcifications. Margins of normal breast structure shall be distinct and not blurred. Here's an example of delineation. It's not even motion, it's just not sharp. These are some linear structures in the patient's breast. They're all benign, but it's not sharp at all. You can see with these coarse calcifications that it's not sharp. It's not blurry, it's just not sharp. It could be malfunction even with the equipment. All right, let's go on and talk about labeling of mammograms. Mammography films or images are medical documents. To make sure there's no misinterpretation of images, there must be a correct label on it. Some information on labeling are required by law, and some information is just recommended. So you have required and recommended. There's a big difference between the two. So these numbers here, 8, are what's required on the image. So these subjects are required by MQSA. The name of the patient must be first and last name. Additional patient identifiers such as a medical record number. They don't want you to put social security number or date of birth as an additional patient identifier. The date of exam must be on there. The standardized view, whether it's CC, MLO, view, and it must be positioned near the axilla on the MLO and laterally on the CC. Facility name and location must include city, state, and zip code, but you don't have to have the street. Technologist identification, whether it's the technologist's initials or tech number 1, tech number 2, tech number 3. It doesn't matter as long as you're able to state and identify which technologist took the image. Cassette screen identification, if you have film screen, or in CR, they have identification where you have to scan it. Mammography unit identification, especially if you have multiple machines at your facility, you must be able to identify which machine that this was taken from. I've even seen where they have room 1, room 2, room 3, or unit 1, unit 2, unit 3. So these are what's required on the labeling on your image. If you have film screen, they strongly recommend a flashcard ID system. It's more permanent. They don't want you to put labels on the images anymore because they deteriorate, they crack, they fall off. It could be lopsided, so they don't want you to use labels anymore on the patients. Now this is what's recommended. Separate date stickers if it's printed. Some digital facilities still print. I know it's not economically viable, but I do see some facilities still print their images, even in digital. Technical factors are recommended. Target filter combination, KVP, mass, amount of exposure time, compression force, compressed breast thickness, and degree of obliquity on the MLOs. And remember, the compressed breast thickness can read out in different measurements. So here's an MLO view. They want it to go up near the axilla, not towards the outer portion. The ID to go at the bottom here if you want to put extra stickers. So this is uniform in how they want it. Remember, full field digital units can submit their accreditation images in hard copy format or electronically. It could be done either way still. So let's talk about failure versus deficiency. So you take your images, you send them in, they don't like them. That is not a failure. That's called your first deficiency. The accreditation body does not notify the FDA, and you do not have to stop doing mammograms at your facility. And you take corrective actions on your own. So they're going to tell you what's wrong with it, and you're going to repeat the deficiencies, and they want you to have it less than 2 months. So make sure that the date on your images that you retake are after when you got your letter. You could reinstate if more than 2 months, and then you could appeal it, say you don't agree with them, with the areas they marked off on the report, or you could withdraw. Like say you're getting ready to get a new machine anyway, or you're moving your facility, so you can withdraw. To sum it up, the first time they don't like your images is called your first deficiency. So say you retake them, you send them in, they still don't like them. That's your first failure, second deficiency. And the ACR strongly recommends that you cease performing mammography on that unit. And you have to do a corrective plan of action. So you retake the images, you go to send them back in, and they still don't like them. That becomes your third deficiency, second failure. And you definitely have to cease performing mammography with that unit. And then you can get in trouble. They start sending out the SOSS team, the on-site team where they comb through your records, they comb through the technologist records, the radiologist records, the medical physicist records, and they're like, what is your problem? Why can you not pass 3 times? And they really take a serious look at you and see what type of retraining you need, and to send you to classes too. So with the anatomy in the breast, we want to depict as much as possible on the image. Remember, you have to see the whole entire image. That's the law, but it doesn't say in one view. You want to depict your lobules, your ducts. You want them well separated, even though we can't see that physically in the image. We know it's there. It's part of the breast anatomy. Our vessels, our Cooper's ligaments, retroglandular fat. We see the muscle. You want try and get the end of the parenchymal pattern in there, and you want your nipples centered. So this is a good mammogram. This is the sternalis muscle. That's medial. You have very good medial tissue, good lateral tissue. Your nipples are perfectly centered. You have the end of the parenchymal patterns. The structures are well separated. They're sharp. They know there's good compression. There's good contrast. So these are beautiful, beautiful images. This is not good images sent in. The end of the parenchymal patterns cut off on the right compared to the left. You don't have the same retroglandular fat. The nipples aren't centered compared to when it's pulled out more. All right, let's look at the MLO view. Remember, you want retroglandular fat starting at the clavicle all the way down posteriorly to the IMF. You don't have all the breast structures in this image here. Here on the right side you do. You have all the breast structures here. You have the retroglandular fat. The muscles are okay. They're not that great. The nipples are in profile, and there's a little bit of IMF on the right and left. There's none. The same patient by a different technologist, they got a little bit more muscle. You do have 45-degree angle to muscle. IMF on both sides, but look at the difference. You see these breast structures here. You see the horizontal nature. They're well separated here, but you have to get this retroglandular fat here compared to the previous view. Same patient, different tech. Do you see the difference there? It's extreme. It's extreme. So with this technologist, they can miss cancer. The radiologist isn't even going to see cancer if it's there because the technologist didn't do good imaging compared to here. All right, here's the same patient, two different technologists. Why is it so extremely different? Well, you can see here, this is a small paddle, this is a large. Remember, there's different number of pixels for the small paddle and the large paddle. So that's why it's small and large. And I've heard technologists say, well, my radiologist doesn't like us to use a larger paddle because it is a smaller image. And I understand that. But if the patient doesn't fit on a small paddle, they have no choice but to go to the large paddle. And this is a fine example of that. Number one, they don't have enough muscle. It's not wide superiorly with the convex border. They're pushing up on the breast, so it's created a fold because they're trying to keep the breast up on the image because the paddle's too small. They do have IMF. There is an air gap here. The nipple's in profile. But there's a huge problem. The tail of the breast cut off, and it's not a good image. The muscle is horrible. So the same patient done with a large paddle, you can see a huge difference. It's wide superiorly with the convex border down to the level of the nipple. You can see the calcifications are very sharp. It has good compression on it. The IMF's on there, little tiny fold here, but it's much better than here. So your technologists really need to be careful when they're judging if they need to use a small paddle or large paddle. I've judged wrong before. And I've taken maybe an image like this. I'm like, oh no, I need to repeat it. At least you repeat it and you learn from it and you don't do it again, hopefully, when you learn. But that's the difference between a small paddle and a large paddle because the patient maybe doesn't have a large breast. And you're like, well, I really don't need to use a large paddle because the patient doesn't have that larger breast. Well, they can get elongated when it goes to the MLO. The breast can really get very long, and therefore they're going to cut the bottom of the breast. All right, cutting off the tail of the breast, having the breast too high on the image receptor. Same patient, two different technologists. And you can see the difference when they're centering the breast on the image receptor. This is too high. They're cut off the tail of the breast here. They have a huge fold in the IMF. There's not real good compression. Therefore, the contrast isn't as good either. Compared to a different technologist, same patient, you can see it's wide superior to the convex border. You meet 45 degrees. The nipple's in profile. It's sharper. The contrast is prettier. And the IMF does not have an air gap here. It's smoothed out by the technologist where they bring their finger underneath and smooth it out. These folds here, you can't see. It's not that the technologist is always being lazy. You can't see it. It's underneath. So therefore, the technologist, the last thing they should do before they go and make the exposure is bring their finger underneath the breast and smooth this out with just one little swoop. It just takes a second to do, but you could see the huge difference that it makes and the prettiness that it makes on the positioning. I consider positioning art. It is a skill. It can make an image pretty or ugly, so that's why I guess I compare it to art. A lot of times I'll comment, oh, that's so pretty, and the patient thinks I'm talking about their breast, but really I'm talking about the positioning part of it. And they're like, thank you. So it's kind of hilarious. All right, here's another example. So we're going to look at our imaginary line, our horizontal imaginary line, and make sure our nipples are centered, which they are. You have retroglandular fat. You want that circle. You want that black circle all the way around. You want your breast symmetrical on both sides. You want good medial tissue. You want good lateral tissue without folds. You want to see the end of the parenchymal pattern if possible. The calcifications are sharp in structures. So these are good. This could have been improved a little bit, but it's not bad at all. I would send these in. These are beautiful, beautiful accreditation images. We've looked at these before. You want to try and get muscle accreditation images. You want that medial tissue, lateral tissue. You want your nipples perfectly centered. Here's a pretty good example. There's a few things wrong here, and I did these. These are mine. The muscle's wide superior, the convex border down past the nipple, which is great. The bottom of the breast is horizontal. The nipples are in profile. There is a tiny fold up here in the muscle. I should have tried to get that out. Beautiful IMF over here, but over here there's not as well visualized IMF. So if I was sending these in for accreditation, I would definitely go repeat the right MLO view. When you're trying to get accreditation images to send in, sometimes you just have to repeat once, twice, 3 times. If the patient's there and you know they're the perfect patient to do for accreditation, you're just going to have to repeat it so you can get very, very good images. That's just is part of the process, and we do want to keep the dose as low as possible for our patients, but also we want to send in good accreditation images. So when I go do consultation, I'll say, no, we need to repeat this for accreditation. And usually the patient doesn't mind. Now in your standard reporting, it's all part of the accreditation process with density per se. Density levels have changed, which they state in the BI-RADS. We know we use the 2013 BI-RADS 5th edition compared to the 4th BI-RADS, which was 2003. So 2 different categories, Category 1 and Category 2. Category 1 is A and B. A, as we know, is entirely fatty. B is scattered areas of fibroglandular densities. So you would send in that category, and then the second category is C and D. C is heterogeneously dense, which may obscure masses, and D is extremely dense, which lowers sensitivity in mammography. So here's examples of A, B, C, and D. In the new BI-RADS, they don't want you to use percentages per se, as we used to use like 0%, 25%, 50%, 75%, and over. They don't want you to use percentages anymore. They want these different categories to be able to differentiate fatty to a little bit of fatty, to dense to extremely dense. So these are the categories A, B, C, and D. And I know there's new software out there that you could purchase from different manufacturers that gives it a more exact density reading. There's now like 4 or 5 of them on the market. So I know that helps with the density reading, with the density laws that have changed in, I think it's 27 states that have the density breast laws. So example ACR images, remember all has to be the very best images from your facility. Look for the retroglandular fat, look for the muscle, look for the centered of nipples, look for the end of the parenchymal pattern, look for good and lateral tissues. MLO is the same thing. Perfect. Wide superior with the convex border down to the level of the nipple. Structures are horizontal. The centering on the MLO, you want to be 2 centimeters above the nipple. You want beautiful open IMFs, nipple profiles. These are the absolute perfect images. So you're going to do checks on your images. So each category, of course, CC and MLO view. Your CC, you want to look at posterior tissue. Is there fat, retroglandular fat, possibly muscle for ACR? Make sure your technologists are leaning the patient forward to get that posterior tissue. Plus, you have to pull on the breast the whole entire time without letting go to make sure you get enough posterior tissue. Nipple has to be perfectly centered. You don't want it pointing lateral. If it is, it's missing lateral tissue. You don't want it pointing medial, or you're missing medial tissue. So you're going to draw that imaginary horizontal line. You must have the nipple and profiles on both views, CC and MLO. You want to see the end of the parenchymal pattern laterally. That way they know you have all the posterior tissue you need. No folds in the breast or the skin. Good compression, at least 20 pounds or more, and they're going to look at that, remember. You want to separate the parenchymal densities, and you want very good contrast, and that comes with good compression too. Your checklist on your MLO view, you want to make sure the tail of the breast is on the image, that you don't position the breast too high on the image. So remember, the center of the image should be 2 centimeters above the nipple. Nipple must be in profile in the MLO view. You want that retroglandular fat from the second rib, which is clavicle, all the way down to the IMF, which is your 6th rib. The posterior nipple line measurement within 1 centimeter of the CC and the MLO view. The IMS must be clearly imaged and clearly seen on the MLO view. Densities are well separated with good good compression. Muscles wide superiorly with the convex border down to the level of the nipple, which is your posterior nipple line, your PNL line. Center of the image, like we talked about, should be 2 centimeters above the nipple and have very good contrast. All right, let's go over some examples here of the radiologist reading. It's a 52-year-old female seen for screening mammogram. Of course, it was compared. Findings: the breasts are heterogeneously dense. This may lower the sensitivity of mammography. Repeat views are recommended to include more posterior tissue in the CC projection. Impression finding of both breasts require additional imaging. The following views need to be repeated for technical reasons. Bilateral CC views. So we had comparisons. We know that from 2010, 11, 13. BI-RAD 0, additional imaging warranted. So let's look at the images to this report. You can see here's the nipples, here's the nipple markers. They're not perfectly centered, but not bad. Good medial tissue and good lateral tissue. So why did the radiologist feel it was inadequate? And they called the patient back to make sure the patient had a very good mammogram. Well, they had comparisons, obviously, because here's some retroglandular fat, but there wasn't very much. They didn't like it. They felt they were missing posterior tissue compared to other years. So they called the patient back for a technical repeat. The patient came back, and you could see the difference. Nipples are perfectly centered. There's a lot of retroglandular fat. You see the end of the parenchymal patterns on left and right breast. You have good lateral tissue and good medial tissue. So if you could go back and look at the previous images that got called back, you could see the difference. Look at that. there is about a centimeter to a centimeter and a half missing posterior. What caused this by the technologist? The technologist didn't lean the patient in good, and they didn't pull and hold the breast as they were compressed. You have to pull and hold the breast as you compress without letting go. And you don't let go of the breast till you're done compressing. You just move your hand forward, compress, move your hand forward, compress, move your hand forward, and compress. So that is very important. You can see what happens. The breast is very springy. Once you let go of it, it can spring right back into the chest wall. You're going to miss that posterior tissue. So that was a good call by the radiologist. They felt it was inadequate, and we're here for the patient. We're not here for the technologist. So it was a good call on the radiologist. I know sometimes radiologists can get afraid maybe of technologist-radiologist relationship. They don't want to upset the technologist by calling patients back sometimes, because you want to have that good relationship and keep the communication open. But it's better to call the patient back. We're here for the patient, and the patient's exam was compromised, so it's better to call the patient back. The technologist will understand, and it really makes them a better technologist because they see these callbacks. They see, oh, that was me, that's my initials, I need to do better next time. Okay, let's look at the next case, a baseline study. So there's no comparison. Findings or scattered fibroglandular densities could obscure lesions in mammography. Impression, the following views will need to be repeated for technical reasons. What's that technical reason? Insufficient posterior breast tissue image on the CC view. So, of course, BI-RADS 0, category 0. So let's look at the images. Here's the images. I like the nipples. The nipples are perfectly centered. I like that. Little folds out here, but not bad, and lateral, and here's the medial tissue. So the radiologist felt there wasn't good retroglandular fat or posterior tissue. Well, how did they know? They don't have any comparisons. This is the patient's baseline. So how does the radiologist know if the retroglandular fat isn't covered up by breast structures? How did they know this? Well, they measured. They used the P&L measurement, and of course we know we measure where it attaches to the breast, but they measured from the nipple, which is fine as long as they're consistent. That's fine. So they measured from the end of the nipple to the muscle, and they got 10.6. And on the CC, they measured from the nipple to the back of the image, and they got 7.1, which is missing a couple centimeters. So you could see here why this radiologist called the patient back. They just felt that they're missing this retroglandular fat. They are missing posterior tissue because they did the P&L measurement, and that's really nice. The patient got called back. The images were repeated. They were better by a different technologist. So it's a good thing. It's a good thing to call the patient back to be able to get better images for the patient. But they did no comparison studies, so there's no way they knew if they had gotten sufficient enough, but they did use the posterior nipple line measurement. And our radiologists use that many times. If they feel that there's inadequate on the MLO or CC, they'll use their tools and they'll get the measurements. All right, here's another example of a screening mammogram. Patient 44-year-old is a baseline screening. Insufficient posterior tissue on the left CC. Finding left breast requires additional imaging. The following views need to be repeated for technical reasons. Left CC. BI-RADS 0 needs additional imaging. So let's look at the images. Here's the right breast, left breast. We're going to see if the nipple is centered. We're going to go all the way across, and the nipple is pointing lateral, therefore we're missing lateral tissue. So I agree with the radiologist. There's a little air gap fold here, and they have good retroglandular fat over here, but here they don't have as much. So the radiologist called the patient back. So here's the callback. The same technologist got her. and that doesn't always happen unless you have one technologist at your facility. Like we have 24. So with the same technologist getting, it's pretty rare. So the same technologist did get the tech repeat, and you could see their nipple is more centered. They got more retroglandular fat and more end of the parenchymal pattern. And guess what else they did? They got more compression. Do you see the difference between better compression and inadequate compression? The structures are more clear. There's not as many summations. Of course, I know tomosynthesis helps with that. So there's not superimposed tissue as much when the computer separates the images slices. But you could see she did a better job. Well, why couldn't she do that the first time? Well, maybe she was rushed. Maybe she wasn't paying attention as well to certain criteria to be able to have a good image. So there could be many reasons why it didn't happen. We don't know it at the time, but I'm glad the radiologist called this patient back to get a better image. Let's talk about radiation reduction in mammography. It's very important to keep radiation as low as possible because we know our patients come back yearly to be screened for breast cancer. It's even more important. I like this little cartoon. I think it's cute about which button do I push. And they said, well, usually we just punch both. One button says detect cancer and the other causes cancer. And patients tell us, technologists all the time, you're giving me cancer by doing your mammogram. And you're like, you have to explain it in BERT explanation, something they're going to understand about background radiation and how much more is compared to natural background radiation. Like maybe it's a couple months more of walking around on the earth. So you have to explain it in more terms that they're going to understand. They're going to understand 1.2 milligray or so. They aren't going to understand that. So radiation dose regulations, it does go by 50-50 breast composition. 4.5 centimeter breast. The phantom is 4.2 plus your disc. So MQSA states you cannot go over 3 milligray per view. If you have 2D digital imaging, on average it's 1.2 milligray. That's with the tungsten tube. 3D imaging, if you do tomosynthesis, on average is 1.45 milligray. When that's added together, it's 2.5 milligray, which is still under the regulated dose of 3 milligray. So you don't have to have special prescriptions for tomo. You don't have to, ask the patient permission to do a tomosynthesis because it's still under the regulated dose. Now, if you have a molybdenum tube, it's on average about 1.6 milligray. It's a little bit higher compared to the tungsten tube. Film screen, on average, it was 2.0 milligray. How can we reduce radiation to the patient? Number one is compression. Compression can definitely reduce radiation. One would be surprised how much more compression could be given without patient resistance. And technologists should use foot pedal compression first when they're compressing, then finish off with the manual compression handle. For every more centimeter of compression, the dose is reduced by 14%. So if the image looks granular tissue is not spread good, look at the compression and possibly repeat would be needed for less summation of tissues in the image. So maybe you would need to call the patient back if you don't feel there's good enough compression and that there's a summation in the image. So patient communication reduces radiation dose. Patient communication is really important given patient instructions. The technologist usually does this. Or if you have a medical assistant bringing the patient back to get them changed, they can also give good instructions of how to have the robe and how to get undressed, not to get undressed completely, get undressed from the waist up. The gown usually opens in the front. So instructions are really, really good. So the instructions for the mammogram, You have to give good communication to the patient to make sure they understand what's going to happen with the test. Especially patients that are having a baseline mammogram, you really want to explain to them that, the compression paddle is going to come down. It's going to put pressure on your breast. Don't let that scare you. This is normal. You're going to hear noise. That's the radiation sound going off. And in tomography, it should have good breathing instructions also because of the grid recoil. So in tomography, make sure your technologists understand, are you going to have the patient hold their breath or just have them hold it for part of the time? Then when the grid moves back in, are you going to tell them to hold their breath again? So there needs to be some type of protocol for tomography for breathing techniques. If good instructions are given the patients, less movement in the exam is achieved. So communication is very, very important. The patients aren't listening. They hear you, but they aren't listening because they're nervous and they're not paying attention to the technologist. So you have to train your technologists on good communication skills. Tell them not to use words like left or right. Tell the patient, step towards me, step away from me, lean forward, step backwards instead of left and right. So there's different types of communication skills that technologists should learn. But you definitely can reduce the dose with good communication. Therefore, you don't have to repeat. So it does reduce the dose. Less images, reduce radiation. Technologists can get lazy in positioning or have a lack of positioning skill knowledge, so you have to repeat many images for that. In my experience of consulting, a technologist will have bad positioning skills. So then when they're in place of teaching the new kid on the block that comes in, they'll teach them wrong. So it just rolls downhill from there. So you have a technologist having wrong skills, teach another technologist that has wrong skills. And you could tell when I go into facilities, they'll say, oh, I taught her. I'm like, yeah, I can tell. Because you taught her like maybe to start out on the lateral side of the breast. Well, we know we don't do that anymore. We start on the medial side of the breast. Just little things like that can make a huge difference in positioning. This is why positioning classes remind us of all the steps that are imperative for a good high quality image. Positioning's evolved. The new equipment has changed. The digital equipment's changed from film screen. So we have learned new tricks. So it's evolved. So you want to be able to keep up with the new skills out there. So don't let your technologists get in the habit of constant additional XCCL views for the loss of lateral tissue on CC. It's okay to do it once in a while because a body habit is you're not always able to get it, or sternum defects that patients can have. So once in a while, we technologists do have to do an XCCL to bring in that lateral tissue. But I've seen where technologists get lazy and do XCCLs on every patient for a screening mammogram. And that's not a good habit to do because it does give the patient more radiation. The regulations state technologist repeat rate is held at a standard of 2% for screening mammography. This is usually per quarter. A total can be done per facility. Tech repeat also per technologist, so you can keep track of facility as a whole and do each individual technologist also. And this is in screening mammogram, not diagnostic mammograms. If the radiologist, physicist, and manager feel this is too strict, they could get permission to get a 3%, 4%, or 5% tech repeat rate per quarter, but it has to be approved. You have to write in, give explanation of why. Maybe you have all brand new techs, you just opened up a new facility and they're all brand new techs, or maybe like, cancer hospital where you're doing a lot of cancer patients. There could be different reasons they'll approve you to get the higher repeat rate. Here's an example of why a technologist would repeat, maybe positioning, motion, underexposure, saturation, artifacts, incorrect patient ID. Maybe they pulled up the wrong patient, X-ray equipment failure, software failure, patient habitus, and others. So this is an example of the repeat rate. So here's mine. I just pulled up mine to give you an example. Out of 876 total exposures and screening mammograms in 3 months, you could see my repeat rate is 0.34. I mean, I've done it a long time, so my repeat rate's a little bit lower. Here it is in diagnostic mammograms. I did 2,030 images in 3 months. And my repeat rate was higher, 1.63, which is still under 2%. We do still try to keep it under 2% diagnostic imaging compared to screening, but it only counts for screening. But we still like to keep track of our technologists, make sure they aren't overexpose the patient for reasons they shouldn't, like maybe they're perfectionist, and so the technologist is repeating when they don't need to, or other reasons. So we keep track of our screening and diagnostic separately. And then it's put into a graph so we can better understand the average. You can see here in diagnostic we have a 5% repeat rate, and then in screenings we have 2%. And then each quarter is put up there. So it's a neat little graph to keep track of. So those are the examples of the images. We will look at a few other images here a little bit later on. But I want to go into equip. I want to talk about equip because it does have to do with repeats and clinical image quality and quality control, which is the heart of each mammography department. Without quality control, your department will fail. So EQUIP, what does it stand for? Enhanced Quality Using Inspection Program. It came out celebrating the 25th year of MQSA passage. So these are issues that the ACR feels needs to have more attention paid to it. Even though we've been doing it all along, yes. They just want us to pay a little bit more attention to these three categories, which is the quality assurance, your clinical imaging quality, and your quality control. So we're going to go over each one of these. There are 3 new questions that are being asked by your annual inspection personnel that work for the MQSA, usually state personnel. So with the EQUIP, it was initiated by DMQS, which is Division Mammography Quality Standards. So we're going to talk about the initiative and how to improve image quality. Remember, there's no new laws by MQSA. They're just elaborating on the 3 issues, something we've been doing all along. It's being checked in the inspection annual process, and there are 3 questions. So we're going to review the 3 questions and the appropriate action needed that the inspector is going to look at. And this is all part of the quality assurance regulations. So it was introduced October 2016. What are most facilities doing? And we're going to talk about that. And your facility is free to design processes that best fit your situation. Maybe you're just a diagnostic facility. Maybe you're just a screening facility. Maybe your radiologists aren't even at that facility that read the images. They could be read from outside radiologists or satellite from hospital, little clinics. So many different ways to provide feedback. So that's good. They give you a leadway into making your own program. It started January 1st, 2017 with the introduction in annual inspection, and they are asking questions in 2017. Then the start of January 1st, 2018, they will start giving level 2 violations with non-compliance of the new EQUIT questions. So what are the violations in mammography and what's number 2? Let's talk about that a minute. Violation level number 1, these had the most detrimental effect on quality of mammography services, like, for example, personnel not meeting standards with qualification standards or continuing education and continuing experience. They're deficient in image quality. So a level 1 is the most serious. Violation level number 2 is considered less significant, like a facility not having an evaluation of equipment by a medical physicist during the past 14 months, or maybe not having proof of the documentation for equip. That is a level 2 violation. Violation level number 3 is the most minor. It's minor in nature, like not having the required documentation of QC test. Even though you did it probably, you just can't prove it, or it's missing. You just need to reprint it when they're looking at the annual inspection. So it's less minor in nature. So level 1 and 2 are significant violations, which requires a facility to submit written plans for corrective actions. How are you going to fix this? So you have to write out a plan, say, okay, this is what we're going to do so it doesn't happen again. Level 3 we know is less significant. Remember, sanctions can be given for serious offenses. Monetary penalties up to $10,000 per exam done under illegal, maybe a legal certificate, or you're not accredited. Suspension of certificate to operate can happen. Revocation and may not operate up to 2 years can happen. Injunction, which can result in a criminal contempt sanction. Or criminal prosecution through FDA Office of Criminal Investigations with probable prosecution with personnel involved with the serious violations. We've seen that. For example, like that technologist in Georgia who was sending out mammography reports as normal and every patient being done, and they weren't even read by a radiologist. She got behind, she got scared, because it has to be within 30 days, as we know. So she got scared and just started sending out reports. They weren't even read. Things like that. That's what they're talking about, criminal investigation with prosecution. All right, let's talk about the equip question 1. Inspection assesses for facility procedures in place to ensure that the daily clinical images continue to comply with accreditation body standards that include image quality, attributes like positioning, contrast, compression, and so on. It must include regular reviews of sample images from each and every technologist and each and every interpreting physician. So this is aimed to make sure your facility has a process in place for giving feedback on any poor quality images presented for interpretation and for documenting any corrective action taken, such as repeating the image for the radiologist before reporting, in diagnostic imaging, or calling back a patient for tech repeat for screening mammograms. Because usually in diagnostic imaging, you go show the radiologist the images for the patient goes. If they don't like it, you're going to repeat it before it's read. But in screening mammograms, they should be read first and then call the patient back, because they're going to have a different date on there. So you want a report. Don't repeat it, then do the report, because it's going to have a different date. Now, inspector will not be reviewing any documentation of correction action, so your method of documenting is strictly up to you. But the inspector will want a verbal answer on the methodology of the process that you have in place. You do not have to have any type of documentation. Is the individual mammogram of high quality so it can be interpreted? That's all they want to know. And if it isn't, what are you doing to make sure it gets that way? It's just a verbal type of documentation that you're telling the inspector that you do have a process in place. Because the inspector say, is there a process or not? And you say, yes, the process is this, blah, blah, blah. It can be any process that your facility wants to use. It doesn't have to be a specific format, which is really nice. They're letting you pick. So it's just, they're saying, do you have a process in place if the images are not in accreditation body standard? What is your process of correcting the problem? So maybe it could be we're sending our technologists to classes. We brought a person in here to do hands-on, or so on. Something to tell them if every single image is not in compliance of accreditation body standard. What are you doing to improve it? All right, question number 2. The inspector was assessed for a corrective procedure when the clinical images are of poor quality that includes a mechanism for providing ongoing interpreting physician feedback to the technologist or other designated personnel like management, supervisors, and so on. So this identifies trends or issues at your facility regarding image quality. Now, the goal of this regular review is to identify any necessary improvements across the facility as a whole. Regular review in place. Like, for instance, like us at our facility, we have a review with our supervisor once every quarter. They randomly pick images of a patient and we go over them together, and they tell us if it's good or not, and if it's not good, what needs to be improved, and they want you to make these corrections regularly, because they don't want like once a year to go over this review, even though that's the minimum required, because you want to catch these areas sooner. That you don't want them to linger on. You don't want to only do a review once a year. Well, if this technologist is not doing good imaging, and if you only review it once a year, you're not catching the problem sooner. That's what they're talking about. You want to identify the trends or issues with your facility. So the inspector will only be looking for one of many possible forms of documentation, like minutes from a meeting, or sign a dated statement or memo stating that this issue was taken care of. That could indicate that your facility has performed this type of review at least annually. But remember, they really kind of recommend it monthly or quarterly, because you want to catch it sooner. So this checks the technologist's positioning skills and if the interpreting physician accepts images for good interpretation. Not if the interpretation is correct. They're just checking and making sure that, yes, this physician checked the images and they're of good positioning. So it's keeping the technologists online, make sure that they are doing good positioning skills. This has to be done on every single technologist and every single doctor that interprets for your facility. Now, question number 3. The inspector will assess for the procedure for the licensed independent practitioner, your LIP, oversight of quality assurance, quality control records that include overseeing the frequency or performance of all required tests and quality control, and determining whether corrective actions were taken when needed. Say, for instance, the detector went out. So what corrective actions were done? Well, you replaced the detector, then the physicists came and did their tests before releasing the equipment to the technologist. Now, the QA/QC program must meet PQI, Practice Quality Improvement requirements, for NAR for the interpreting physicians who are subject to PQI requirements. So the suggested is quarterly meetings with the lead QC mammography technologist, medical physicist, and lead interpreting physician of the department to look over the QC tests, make sure they're written down, make sure the results pass, and to make sure that it's all documented and signed off by the technologist. We do this once a quarter at our facility. It's great that they keep up with this, because this is like I said, the heart of the department. Your quality control must be done in a timely manner when they state that you do it per manufacturer, and that not only is it done, that it's done correctly, and that the limits are set, and that your equipment passes. So they're asking, hey, you need to make sure and document that you have had meetings, that this is checked upon by the lead QC mammography tech, your physicist, and your lead interpreting physician. Documents don't even need to be signed. There just needs to be documents. But the time and date need to be on there. You could do this as Skype. You could do it video conference, telephone conference. Not everybody has to be in the exact same room. As long as it's documented that you had the meeting on this date and this time, that's what they're looking for, to make sure that your quality control is done, that it's checked by personnel in charge. So that's what question 3 is. Pretty much the easiest question. So here's examples of facilities and the steps they've taken to stay within the equipped laws. Record QC tests performed by QC technologists, medical physicists, that the medical physicist says, okay, I checked the records and they're correct. Taking any corrective action as a result of the testing. Records routine and non-routine equipment services like PMs, maintenance, check the output rate, and so on. Records of QA meetings with dates and times. They want signatures. You don't have to, but they would like it. Descriptions of orientation program for operators of mammography equipment, including its duration and content. Say you gave a class on how to operate the equipment. Like, say if you have too long of time of exposure, what are you going to change? Like, you would change to auto time and bump up the KVP, things like this that you taught your personnel. Procedures for proper use and maintenance of equipment, like cleaning, what type of equipment are you going to use to clean? Do you use sandy wipes? You know, what's the process? Posting of proper mammographic techniques, including pertinent information on positioning, compression, appropriate image receptors, different imaging modes like auto KVP, auto time, manual, KVP target filter combinations if applicable, breast implants. So that's what they want to see with that. Precautions to protect the operator of equipment, the patient, individuals, surrounding areas for unnecessary radiation exposure, and the use of PPE for your personal protection with your equipment, like thyroid shields, lead shields, face mask, things like that. Policies and procedures for employees responsible concerning personnel radiation monitoring for dosimeters and knowledge of Valera usage. Make sure your technologists are using their dosimeters, that stays at work. They don't take it home in their purse or on them to get incorrect readings. Policies and procedures for cleaning and disinfection directions. If you have 2-minute wipes compared to 10-minute wipes, so that has to be documented also. Blood contact with mammography equipment policies, like doing post-procedure mammograms. Patients can bleed. You have to have a blood kit nearby if it's a lot of blood. So you have to document when you wipe off blood. That has to be documented in mammography as a law. Remember, keeping mammography quality high. There will be less need for facilities to undergo an AMR, or additional mammography review, and a PPN, which is patient provider notifications, which can be very embarrassing for your facility. Remember the new digital QC manual? The FDA specifies that the new manual may be used only for full-field digital mammography systems without advanced imaging capabilities like tomosynthesis or contrast enhancement modes. So the new ACR manual will go into effect July 2017 for facilities that choose to use it for their quality control program. So remember, it's all or none. You can't use half the program. If you choose the new program, you must use the new QC digital manual with the new Phantom and the new QC tests that go along with the test program, with their usage of daily, weekly, monthly, quarterly, or semi-annual. So remember, it's all or none. And this is all in the new, it came out August 2016, the digital mammography manual, quality control manual. This is the new Phantom. It's not like the little one that we had. This is the new Phantom. It has 6 fibers all the way across, 6 spec groups, and 6 masses. It's easier to read. There's not confusion with different lines as the old one had. It had some fibers here, spec groups here, masses. It's confusing to learn for a new technologist. So when they constructed the new one, they made it all in the same line, which is really nice. So let's look at some mammography images to critique for accreditation body standards. So these, I like the muscle. I like they have the tail of the breast there. The nipples are in profile. The bottom of the breast isn't perfectly horizontal, but I don't like the IMF. See, the IMF shows down here, but not on top. So these I would not send in. Try if you really want to use this patient, or if you're limited to patients. I know some facilities don't do a whole bunch of patients daily. So it's hard to get accreditation images within the time that they allot you. So if you want to try and use this patient, bring the patient back. I like this MLO view. The muscles wide superior with the convex border down to the level of the nipple. There's a beautiful IMF, the bottom of the breast horizontal. Just make sure and have that nipple perfectly in profile, because they would dock you for this. Not that they would give you a deficiency, but they're going to write it on the report. But I do like this image here. Here's another good image. The muscle could be a little bit wider maybe, but it's a good muscle pattern. The bottom of the breast is horizontal, but there's a fold in the IMF. The IMF is on there, and the nipple's in profile. So this isn't bad, just a little bit of correction for this. Remember, they're gonna document something. But that doesn't mean they're going to give you a deficiency letter. So if you get desperate, you're going to pick the best that you have. I like this. Here's a muscle. This is a pure fatty breast. You can see the mole here. The nipples centered. They have good medial tissue and good lateral tissue. I like that. Here's an MLO view. Wide superior with the convex border. You draw that 45-degree line to the muscle. Nipples in profile. The bottom of the breast horizontal. The IMS on there. It's got a little bit of fold. It's not perfect, but this is not a bad image to use. I would use it. Here's a CC view. I like it. The nipple is perfectly centered. The structures are well separated. You have good lateral tissue, good medial tissue. There's a little bit of neck in there. So be careful from this tiny, tiny artifact here. That's the only thing I don't like about it. Otherwise, it's beautiful. You have good retroglandular fat, a little bit of muscle here, but be careful. This is very, very medial. I don't know if I would send that in. You definitely would get docked on it. I love this MLO view. Wide superiorly convex border down to the level of the nipple. Make sure that you use your P&L measurements from the CC and the MLO view. The tail of the breast is up here. And IMF's on there. I like it. Very pretty. I like this. This is, I know this patient, this is a sebaceous cyst. It would be BI-RADS 2. Wide superior with convex border. Beautiful IMF. The nipple's not perfectly in profile. Even though the BB is, the nipple isn't perfectly in profile. So be real careful at that. But like I said, they're going to mark you off on something. It's not going to be perfect, but you can at least pass. Let's talk about this image. I don't like it. Why? There's absolutely no IMF. They will give you a huge mark on that, but the nipple is in profile. I like the wide superior muscle all the way down here, 45-degree angle. This is a very, very dense breast, but I would not send it in without that IMF. That is very high criteria, and that's one of them. IMF is up there on the list. I like this image, wide superior convex border down the level of the nipple. She's very dense. There's IMF here. Just pretend there's not a clip here. But the nipples in profile. There's a tiny fold in the muscle, but not bad. I like it. This would be something I would send in for the ACR. It's something. And remember, you can't just pass an image. They do have radiologists that read it. So if there's something in the image to be called back, they'll read it and call and give you a deficiency on that because there's something in the breast that's of concern. So they do have radiologists that read these images. I like the CC view. The nipples centered. There's muscle, retroglandular fat, medial tissue, and lateral tissue. The end of the parenchymal pattern isn't on there perfectly, but it's a good image. Just be careful that there's not an air gap here. There's a black triangle here that can indicate medial air gap. I love this MLO view, wide superior to the convex border, nipples in profile. This right here is the implant paddle. If this shows up a lot on here, I don't think they will like it. There are newer type of implant paddles that you can use for small breasted patients, but look at this beautiful IMF, nipple in profile. So I would just use a regular 18 by 24 paddle on this patient. I wouldn't have this implant paddle in there for accreditation. That's a lateral view. We don't want that. So I hope you enjoyed the class today. If you have any questions, you can write my company and let them know. I hope you learned the different categories and how important accreditation is, the new equipped is, and the process of accreditation body. And I thoroughly enjoyed teaching this today, and I appreciate you listening. And like I stated, if you have any questions, let us know. And thank you once again. I'm Deborah Thames, and I appreciate your time that you took with Advanced Health Education Center today. Thank you very much.